Oh, Abby, you joined. Great.
Here's the little cutie, Susan. Thought you might want to see him.
Oh my gosh.
He looks like a little tiny lab.
He's like a mini lab. That's hilarious. Is it like a designer brand or was it an accident?
Rescue.
Oh,
But
that's so
I don't think it's
awesome.
an accident. I think it's artificial
It's a,
insemination is the only way this thing works.
Yeah, I was feeling bad for the Chihuahua there.
The lab is the mama.
that's hilarious. That's great.
Yeah,
Cute.
he's a cutie.
All right, we'll just give it a couple of more minutes. I know Dave is joining us too. So thank you, everyone. There's Dave. Thank you, everyone, for joining. Yeah, there you are. So we sent out the agenda and some information last week, and then we updated it a little bit. So, we'll get through the agenda, but there are a couple of things that I just want to do up front. First, Robin Lunge is here, and for folks who don't know this, Robin is retiring from state service. She's way too young to retire, though. And she wanted to come in and say goodbye. And I'll turn it over to you, Robin. Maybe you could tell folks what you're doing next because it's really exciting, I think.
Yeah, I think it'll be good. Yes, I just wanted to pop in and say hi and thank you all for your involvement on the Green Mountain Care Board, Primary Care Advisory Board. I've been in and out of these meetings over the last 8.5 years while I've been on the board, and it's always been great to work with you all. So I just wanted to pop in real quick and say hi and bye. My last day at the board is a week from Friday, so April 4th, and then I'm moving on to Senator Welch's Vermont office, working on healthcare and immigration. So still be around, but leaving the state service. So that's all I really wanted to say, but felt like it came full circle to just be able to come say hi.
Yeah, because when you got on the board, this board, like how long have you been on the board now? How many years is it?
8.5 years.
Yeah, because this group was just starting.
Yeah.
And you were very helpful in getting us off the ground. So
Robin, I'm so happy to think that there will be a person and a face that I know in Senator Welch's office because I think everyone on this group knows that half the time the changes that we need to be working on and need to be made are not
federal.
Not in PCAG's purview, not in Green Mountain Care Board's purview, et cetera. So I think that's awesome. And you'll be hearing more from us.
Great. I welcome it. I look forward to hearing more in my new role.
I would also say, Robin, that I'm excited because since Tiffine moved to DC, it's been difficult to have a good contact in Vermont for Peter's office. Yeah. So I'm really excited.
Good. Yeah, I'll be working closely with Tiffine, certainly, and as well as the rest of the staff. So I think it'll be.
And you're staying in Vermont?
Yes, I'm in the Vermont office. Yep. Cool. Well, I will hop off, but I just want to say thanks all for your service and hope to stay in touch with you as we move forward.
Thanks, Robin.
Thank you. From us too. Best wishes.
Thank you. Bye-bye.
She's out west too, so she's visiting a friend. So I don't know, she's going to go and have a good evening. So it was really nice that she was able to stop in. And it is nice that you all have a familiar, reliable, smart face in Peter Welch's. They all are, but it's nice to have somebody there and also in Vermont, like you said. I think that was you, Michelle. So, so why don't we, let's see, we can do introductions. Are there, I do want to introduce a new face from the Green Mountain Care Board, but I think everyone knows each other on the PCAG. Is that true? Or do we need introductions? It's up to you all.
I can introduce myself.
Sure.
I'm off camera. I'm multitasking with my kids right now, but
Okay.
I'm Michelle Farnsworth, and I'm the Blueprint Program Manager for the Burlington Health Service area. And I just saw this meeting on the Green Mountain Care Board website, and I looked through the report, so I was interested in attending. And I
Awesome.
support the primary care practices through the Blueprint in the Chittenden County. So very interested in this content.
Thank you, Michelle. So good to have you here. And we have these meetings. Well, we're going to talk a little more about that tonight. Usually every other month they have been on the cadence, and they are posted on our website. Tonight we're going to hopefully get into some thoughts on where we go next. We've had this, we started out as a statutory obligation through the legislature. The PCAG was created to address administrative burdens back 8.5 years ago, as Robin was saying. And then we, under Chair Mullen, continued this primary care advisory group under our existing statute at the Green Mountain Care Board that allows us to create advisory groups. So here we are today, 8.5 years later, and let me just pull up the agenda. I know you don't have to put it back up, Abigail. While I'm doing that, I am going to introduce everyone to a new staff member with the Green Mountain Care Board, and Abigail is also somewhat on vacation. So I don't know, Abigail, if you are able to introduce yourself. If not, we can just send out a quick note afterwards.
I can do that. I'm kind of on and off, but here for meetings. I'm Abby. I joined the Green Mountain Care Board in December. I'm supporting a lot of Kristen's work, doing administrative and communication and legislative, anything she needs. I have a background in public health and public administration. And yeah, sorry, my brain is still a little jet lagged, so I feel like I'm talking in a dream.
That's wonderful. And Abigail will be supporting me with this group. As she mentioned, some of Kristen's work is transitioning over to Abigail. Actually, most of Kristen's work, because folks probably wouldn't know this, but Kristen has moved into a role as the communications and information officer for the Green Mountain Care Board. You may still see her face occasionally and get communications from her, but we have had a bit of a transition, and I wanted to introduce folks and let everyone know about the new additions and really great advancement for Kristen. So we're excited. Let's see. I think we should get to the next item, which is the open discussion of priorities and next steps for the PCAG. We have a couple of documents. Faye has sent a document that I don't know if folks had a chance to look at. We can pop it up on the screen, Faye, if you'd like. We might want to do that. We can talk about that. We sent an article that Dave Merman sent along, and Dave also is going to be, he's, I don't know if I've made this official announcement, but he is our board member for the PCAG. There'll be other board members that come in and out, but thank you, Dave. I think he's a good choice with his clinical background. So Faye, do you want to dig in first and maybe talk about your thoughts, and then maybe we can open it up for a discussion?
Yeah, I can kind of get the ball rolling. I think for me, I have I guess what first got me thinking about sending this out was a couple of people did ask me about joining PCAG and showed some interest. And I got thinking and looking at the website, and there's actually 17 people on the website listed as board members. And I think not a majority of those show up regularly.
Yeah.
And so sort of thinking about our membership was one thing that I had in my head. And the other is just sort of this feeling that on some level, I think we've gotten a little predictable. I think all of us could know a lot about what the others are going to say or what our positions are going to be on things. And, maybe it's time to think about that, making it a little fresher of a group, perhaps, or at least see who has energy and enthusiasm about it. And then there was one other thing that I was thinking about. Sorry. Oh, just that I realized that we only had like 3 meetings for all of 2025 on the calendar. And I thought, wow, if in this crazy time with healthcare, when so much is up in the air, why are we only meeting 3 times? Did someone make that decision, or did that just kind of fall off the calendar? And that's one of the things that just got me thinking about sort of energy and what do we want this group to be? Should we think about membership, about term limits, about, this is all stuff that's in the letter if you've had a chance to read it. But, things like, do we work more between meetings? Do we send out emails to each other? Do we have little working groups or subgroups? Can we get more done? Is there enthusiasm for that? Do we open the doors wide to anybody who wants to be on it, or is it getting unwieldy with the size? So those were all things I was thinking about. I have no idea what the answers to any of this is, but I thought it was time to talk about it.
I'm raising my hand because I want to just say one thing up front, because our chat is turned off. We can turn that back on. I think we had it off during the pandemic. Chat's got a little crazy during the pandemic, so we could probably turn that back on. The list of membership, we will get back to that and clean it up. I heard from like Elliot, who has moved on. Like there's a couple of people who've just not on the PCAG anymore because they're doing other things. So we can take care of that. Thanks, Faye. And this should just feel free to raise your hand and interject, and let's start the discussion. So the next hand I saw was Dave Merman.
Faye, thanks for spearheading this conversation and where to go. I think it's important. I've been coming to these meetings for a little over 2 years, and I'm I think maybe like many of us, although now I'm more meeting out than I used to be. When I was doing clinical medicine, I had a lot, that was like the full-time thing, and the meetings were occasional. I felt like I came to meetings with so much energy. Now that I'm do so much meetings, I get a little meeting fatigue. And I kind of think that maybe which is not to say we shouldn't do more. I just think we need to figure out what is the goal of what are we trying to accomplish here? And I think maybe a couple things, so I have a few thoughts. And one is, I think, if the PCAG is to advise the care board about primary care, then I think that could be one goal, is to sort of advise the care board about how our actions could positively impact primary care. But then I also think, and maybe when you were talking there, it resonated with me more, is that we have a group of primary care providers who are very passionate and active and mobilized to do work. And the care board actually isn't the right audience for I think a lot of what we could accomplish. And so one is, I was trying to figure out, should we, and I mentioned this to Susan the other day, is should we have AHS representation on here? Because I think with regards to Medicaid and primary care reform work, they tend to be, the bigger node of focus. Not to say that we can't be at the Green Mountain Care Board. I feel like we have been very hospital focused, which has implications elsewhere for sure. And I think understanding that nuance is really important for us to know and contextualize. But those are kind of just two thoughts. I like the idea of leveraging the knowledge and passion and engagement in this group to move primary care forward, or maybe stop moving primary care backwards, which I feel like is unfortunately the current situation. So I don't know. That's sort of just a couple comments, but I would love to. I wonder if somewhat, and I don't know, Susan, maybe there is like a mission statement of this.
There is. I actually am reading it. We have a charter.
Yeah.
And I could say, again, we need to fix the chat because I could just drop it in the chat, but it's turned off. Maybe I can try to turn that on. But it is like, if you read the charter, it says GMCB may seek input, advice, or recommendations from one or more participants in the PCAG relating to clinical matters within the participant or participant's expertise to help inform GMCB's duties outlined in 9375, or to advise the board on a report or general matter of interest. So I love your idea. And we do have an employee from the Blueprint tonight, which is great. And I can circle back with Brendan Krause and folks at AHS. And I think it would be great to have them as a member. But yeah, love those ideas.
I guess one more thing. I'm feeling a little bit of urgency. I think we all have been for years, but I feel like we just, my view is that, we've passed a tipping point on so many things in healthcare, and we're going down. And so it'd be really wonderful to have, an ability to brainstorm and do some idea generation of like, what are the options that we as Vermont could do to try to support primary care and not just support primary care, but rebuild primary care. I mean, I feel like it's so challenging right now for so many parts of the state. But anyway, I'm known to talk too long.
Dave, just to project as we go along. The next person I see is Lee.
Okay, now get my mic on. And I want to start out by thanking Faye because she's always been very pushing us forward, which I think we need. And I've been on this group for about 5 years, so I'm probably one of those people that Faye's thinking about with term limits and getting rid of me. But we were very much more active 4 or 5 years ago. Oh, I'm getting a message that they're lowering my hand, which is fine. And I have also noticed the decrease in the meetings and thinking maybe we don't have a purpose anymore. And maybe what we really need to work on is figuring out what our purpose is and then going forward from there. And if that's in advising AHS or advising the Green Mountain Care Board, or what we should be where we need to be to actually have some input and some influence on what's going on, because I just don't feel that we've really been that active or that productive in the last probably 1.5 or 2 years. And so that's where I want to go. I want to get more productive and more active, and let's do some things that are going to help primary care. I mean, just being an advisory group but not actually helping is not actually helping.
I will say thank you, Lee. I think I may have said this, I'll say it again. The reason this group was started was to address administrative burdens like prior auth, like it's like when you share records, the term is escaping me, but I could look it up. But that was the initial goal. But I agree, Lee, like I think a lot of those things have improved, but I'm sure there's still work there, but also to Dave's point, the environment, like right now, there's so many pressing issues. And if you all can come together and decide where you want to go, we can let you know what we need too. I think that's part of it. We're obviously the Green Mountain Care Board Primary Care Advisory Group, so we can interject, like Dave was saying. I think that's a good next step. So thank you, Lee.
Can I add one
Yeah.
quick interjection on that?
Please.
Is, one thing to just throw out there is we had a hearing today about a settlement that UVM Health Network is proposing to deal with overages, of which in that settlement is $11 million to non-hospital based primary care, non-UVM Health Network primary care. How that money is going to get distributed is totally not worked out. So if there are ideas that we should think about, we're looking, I think that this is a monster of a project that people have been working on, and that is an incredibly important detail. But that is not that it's not defined. So if you have ideas, methods, ways to work within the legal system, how that money should be distributed, that I think would be the pinnacle of advice from the PCAG to the Green Mountain Care Board, in a very pressing way. So
thank you, Dave. And I didn't even mention what we did today. It's been a long day, so thank you. A lot of work. We can share the recording. It was the first item on the agenda today, so I'd encourage you all to listen to that. And I see Eileen is next. Hi, Eileen.
Hello. The comments that have been made so far were thoughts I had when I read Faye's write-up. I think we have accomplished something. We had gotten together, we had done some work, we actually made some changes, made some points, made some presentations, and we did a bunch of that as a group offline. So I think there was already demonstration that we can do that as a group. My thought was that if we came up with, I think we could do that again, and it wouldn't take very much time or effort to identify what are the top 3 or the top 5 areas that need to be addressed. And yet, that's the good thing about this group. Okay, here's the top 5. One of these, we cannot necessarily affect change. We chose to include it anyway because it's number 2 or number 3, even though we cannot address that. We're making that point. And then looking at what can we actually accomplish, what can we address, which doesn't always mean that we make the change. We're making the point or putting the information out there, putting it together. And lastly, what this group can be helpful for if we do that is having the right people here to then say, well, the Green Mountain Care Board can't really address this piece, but it can go through AHS, as you've already mentioned, and having the right people here to listen to that. So if we come up with those pieces and meet more often, I think, even if we do outside work and prioritize that, then what are ones that we can accomplish and who are the best people to do that with and who do we address them to?
Yeah. Thank you. I mean, and we have had periods, like you said, where, and you've done a ton of that. Everyone's worked really hard outside of this group, but that's super helpful. Thank you. I don't know where 2 is. Oh, there you are, Rob Penny.
Hi, thank you. I just building on the last couple of comments as far as our interactions with the Green Mountain Care Board. I guess I feel like I'm one of the founding members, so maybe I've been here the longest. But I've found the Green Mountain Care Board members, even as they've changed over the years, have been very receptive to our comments and complimentary as to our contributions. But I think we've all had the impression over the years that as much as they would like to help, they're limited in what they can do by their legislative mandates. And a lot of what we really want to have done, they can't directly affect, such as the longstanding administrative burdens, the shortage of primary care physicians, all the other, the many things. So it certainly makes sense to include other people in these meetings, such as somebody from AHS, people who have the authority, at least the input, to make some of these changes, which the Green Mountain Care Board's not empowered to do, as far as my understanding of what they're empowered to do. And just tangentially on the membership, I think we did have a few years back some criteria as to people who wanted to be members had to attend a certain percentage of meetings. It might have been like 50% or something if they didn't. So might want to look at that again.
Yes, definitely. And again, going over the list on our website, there are folks who haven't been to meetings recently, so we can clean that up. But I'm taking a lot of notes here, so a lot of follow-ups and to-dos, and I think that's an important one. Thanks, Rob. Let's see.
Can I just ask a favor on that too?
I'll just go to you, Dave, after every, like,
oh, sorry.
chime in. No,
I don't
this is great. This is great.
So I think one of the things with administrative burden is it's like, it's far beyond what the state can do, right? So, but oh my gosh, I got a barking dog. But I guess what I was saying, if you have thoughts on what the state can do with regards to administrative burden, even if it's not within the Green Mountain Care Board, I think this is not a bad place to try to develop those thoughts and then try to figure out how to, leverage the Green Mountain Care Board with the legislature or wherever that could occur. I have a thought on administrative burden that I don't know if it adds to or reduces, but there's some rumbling in different states about having a statewide EHR, which has been epic, as mentioned for Washington. I think Oregon's looking at doing some larger implementations too. And I don't know if the transition to Epic often adds to significant provider burnout, but at the same time, there's like new tools like AI scribes with an Epic that you can frighteningly walk into a room and record. It documents a note, and it's remarkably good. I haven't actually used it, but I've read the notes of my colleagues who use it. So that's something for administrative burden that I think we could talk about. The other one I think is recruitment and retention. I think we should. One of the things I've been really worried about is recruitment and retention to non-hospital based primary care. I mean, and this group is all, I think at this point, non-hospital based. I'm not totally sure.
No, we have some. No, we actually have some.
This group today.
Yeah.
Or largely, a lot of non-hospital based primary care, FQHC associated, and I think that those are areas that, from a data standpoint, lower cost, high quality. But how do we get new people to join those young grads that come out of academic programs to join those practices, and get them to stay and keep them engaged in the community? And those are things that I think falls within the Green Mountain Care Board's overall, statutory goals. But I don't know if we have mechanisms of which to do that. But again, I think leveraging our position within the state, I think has some advantage outside of our specific regulatory actions and duties.
Definitely. Thanks, Dave. Michelle.
Thanks. First, to kind of piggyback off of some of what Dave, I think, might have been getting at, specifically engagement for new providers to go into non-hospital based practices. I think part of the barrier that I see for that, at least at the APRN level is that you still have to have a collaborative agreement for 2 years. So you've got to start somewhere where you're not in a solo practice. Second of all, I think that the cost of running a solo practice right now with all of the mandated reporting is sometimes a barrier. And when you speak of the AI, I work on the EHR committee at Gifford, and granted, we have our problems. But one thing that we've been looking at with the AI is if you use AI to capture your note, how is that mandated data then being collected? Because currently in an EHR, when you fill certain fields is where you gather your data that you have to report out to Blueprint, that you have to report out to CMMI, that you, etc. And if the scribe system is just dropping a beautiful soap note, which there's nothing wrong with that, but you're not necessarily getting those same data points. So that's a place where people have been struggling because we have a large amount of mandated reporting of data. To go more on to things that I had stuck on my personal list, I too had reached out and said, hey, how come we haven't had a PCAG meeting lately? Did it drop off my calendar? Because I too feel like there's so much going on in healthcare right now that we should be active in trying to support our primary care providers around the state. I think not only AHS, but also DIVA might be an important person to have because much of the Medicaid stuff goes through them as well and the rulemaking. Another issue that I see organizationally is that people are not allowed to work to their fullest scope of practice due to organizational rules. Specifically, UVM is doing that right now, not allowing APPs to be provider of record for admissions. It is absolutely within their scope of practice, but it's a bylaws issue at UVM. And so there are lead APPs there working on that right now, but it's troubling that we have MAs, LNAs, LPNs, and RNs working out there that are not working to their fullest scope of their education and practice. And that's hindering our ability to give good primary care across the state. Another thing that I think is a bonus, and I think it's really important, and I don't know that everybody knows this, is that scope of practice per Secretary of the State for licensed practical nurses was recently expanded in the state of Vermont. And so the limitations that previously were on licensed practical nurses are pretty much removed as long as there's organizational education. So if you have an LPN in your office that's going, hey, I can't do this, I need someone else to do it, you might want to take a look at those new scope of practice for them because it was not widely publicized when it happened.
Are those,
go ahead.
oh, Michelle, are those on the website? I don't want to like bother you, but we can just look it up and put it in the chat.
Yeah, it's public, and I also have an email I can forward you really easily.
Okay, let me see if I can find it. Keep going. I'm sorry, I didn't mean to interrupt.
No, you're fine. A couple different people talked about the makeup of this group. I do think that's super important. I was super proud to be the first nurse practitioner on this group, and subsequently there are more advanced practice providers. There's a PA, there's other nurse practitioners. I do think that's important that we maintain across the spectrum. And I also think geography is important. I'm in the center of the state. I'm not sure on the APP level that the southern half of the state's represented. I know that we are on the MD level, so that's good. And we reach to both corners, but I think we need to make sure that we continue that reach. And I think the last thing, we all talk about administrative burden. A lot of that, I hate to say this, but is because people are stuck in their ways. A lot of administrative burden has been streamlined, but insurance companies don't want to change their mind. Specifically, things like over 3 years ago now, APP is consigned for home health. There's still insurance companies out there that I fight with on a regular basis who say, oh no, it's got to be an MD or a DO. And that's not accurate. So we have to educate our care partners and teams that they need to stop making extra work for us.
Oh, you found it. Thank you, Kristen. Great. Oh, I thought you put it in the chat. I think Kristen found it, so she's going to share it. Thank you, Michelle. Really, really good points. I wrote them all down. Next is Faye.
I just wanted to say one quick thing. I know Lee was kind of joking when he said I wanted him off the board because of term limits, but truly, Rob and I at least have been here since the very beginning, and I fully would include myself in that. I think if we did decide that we should mix up the membership, that that people could get back on in a couple of years, or I mean, I just think those are things to think about. Especially since there is interest from some in one of the people interested that I talked with is a pretty new physician, you know, maybe 3-4 years into practice. And I think representing demographics in various ways, you know, young, old, and like Michelle was saying, different geographic areas and licensure and all of that. So anyway, I would include all of us as potential step downs who've been around a long time, and it's not. It's just an idea to sort of keep fresh conversation going is why I brought that up. And then when David mentioned this money and how to disperse it, that seems like a really great thing for either a work group, a smaller group of PCAG to work on by email in between times, or maybe the whole group. But like having a specific task like that, I think is really helpful for us. So I would say bring that on and see what we can do with it.
Thanks. And that's on us. That's on me and my team to do that. And Abby when she gets up to speed. So next I see Lee.
Okay. I want to, I think we've actually discussed this here to have a statewide medical record a year ago, maybe 2 years ago. So I'm going to second Dave's motion. I know it wasn't really a motion, but I'm going to second it anyway. And you know, that would take care of a bunch of administrative burdens because we would all have the records that we need. And they'd be easily accessible. And that is irreplaceable. Then, you know, rather than trying to, you know, comb through this and then comb through that and try to find what we're looking for, it would be an enormous, you know, you want to talk about getting rid of it, some administrative burden. Now, you know, one of the things that would have to happen is that, you know, people like me in a direct primary care practice who don't have to bill, we would be very happy not to fill out all those little check boxes in Epic, and we'd have to be able to finish a note without checking them. Because we don't have to. But the other thing that I, you know, people keep talking about this, and, you know, we've talked about a 12% primary care share, and we're still not getting paid what everybody else is getting paid. If you want to retain and recruit, that's a factor, you know, as I talk to everybody, and I can't speak to what it is in the nurse practitioner realm, but you know, if you got people coming out of medical school, okay, and they're thinking about going into primary care, and you offer them, by definition, if they're thinking about going into primary care, they're interested in a wide variety of aspects of medicine because they wouldn't be thinking about going into primary care if they're not. And you offer them a dermatology job at $600,000 a year and a primary care job at $200,000 a year. That's an easy decision. Okay, they're probably already a little bit interested in dermatology, and if they're going to make 3 times as much, wow, piece of cake. So we got to really work on paying us. And I don't think we necessarily need to be paid more per se, but everybody else needs to be paid less. Because that getting the pay to be more equal is a big issue for recruiting and retaining people. You know, obviously, I think we need to meet somewhere in the middle rather than just cut everybody else down. But I do think that, you know, as long as we're making whatever I've recently read, $220,000, and the orthopedists are making $600,000, and the dermatologists are making $800,000, you're not going to get people into primary care. It's not going to happen. I mean, when I started in this game, you know, I was making $44,000 a year, but the neurologist who was next door to me and in the same group was making 47. So there wasn't that much of a difference at that point, and it has gotten way out of control. And maybe that's one of the things to do with the $11 million, just give it to, a share to every primary care physician or primary care provider. Actually, wait, I will, before Michelle and Ellen kill me, rightfully so, I will amend that. But I do think that we need to figure out how, and money, I don't want to be terrible about it, but it's a big factor. These people have $300,000, $400,000 of medical school debt. And again, I can't speak to the nurse practitioner part of that, but they have tons of debt. And if they can't pay it off, or they look at it and say, I can pay it off in 3 years if I go into that, and in 15 if I go into primary care. Again, easy decision. I'm going to shop now.
Thanks, Lee. Good to be reminded about that and go on our list. Thanks, Lee, and I'll turn it over to Paul Rice now. You're next.
Hi, everybody. Thanks, Lee, and thanks, Faye, for and all the others for bringing up these issues and sort of reimagining this whole committee. I think the administrative burden is what it was put together for. I was on it early on, went off it, and then joined it again. With the hopes that there'd be a lot more work that we could do, and I think there is, but I think it really is up to the Green Mountain Care Board to decide what they want this committee to do. We're your advisors, and I think you mostly have to let us know what you want us to tell you. I think reprioritizing sort of what the issues are and deciding which ones we can actually tackle is the most important thing. I mostly retired, probably 95% retired in December, and on my way out, got to thinking about stuff, and really prior authorization and formulary management is still a big thing. But I tell you, I don't think it's the biggest thing. The biggest hassle factor for me is the lack of access to care for my patients. That always created so much hassle trying to get people the CT scans they needed, and it was going to be 6 weeks out. Trying to get them specialist appointments, and especially in mental health, critical mental health things, but also in certain of the specialties where we've got to send them to Dartmouth or call a different hospital, or it's really a burden on the practices and really mentally on the practitioner. So access to care, I think, is a big one. Someone mentioned that the insurance company, I think it was Michelle, some of the insurance companies, others, haven't been able to sort of change their ways in some of these hassle factors. I'm going to throw it out there, and I know it's not a popular thing to say, but we're our own enemies at this point, I think, in that, I think it served its purpose, but the blueprint rules and certification and reporting are a tremendous burden. And the sort of amount of, it's not even really clear how much money is attached to that, but it sure costs a lot of money, is a lot of hassle to do the reporting of the blueprint. And one thing was never required was there are NCQA standards for specialists, and we never put those into place. And that would make primary care practice much easier, because it requires reporting back in a certain amount of time, access standards, all those kind of things, which makes care much more efficient and much higher quality. So maybe it's time to do away, at least suspend the blueprint for primary care, the NCQA standards for primary care at least, and look at them for specialty care as a way to help primary care provide better care. The other thing on EHR, tremendous, those who have gone through it, tremendous stressors switching EHRs. So for a practice, or especially practitioners like I was in the last 3 to 5 years of practice, it would be all hell. It would drive a number of people who are within 5 years of practice, retirement, they would retire because they will not want to switch an EHR. So that has to be taken really cautiously if that's considered, and it has to be paid for because practices aren't going to be able to pay for that themselves, especially when they've already invested in what they have. So yeah, again, so back to the prioritization. Have to decide, and maybe the first charge for this group is to decide what are the most important things that could potentially be tackled and which would have the greatest impact at reducing. I've always said that if you reduce the hassle factors, you're actually, quote, paying me more in reality. When I was first into practice, it was not uncommon to have 1,800 patients in a panel for a primary care practitioner. That is totally impossible now. And a lot of it is the documentation. People are more complex. There's a lot more to manage, but it's also that you need to have access for those people. You've got the labs and the documents coming back to sign off. And so panels of 1,000 are probably about it to be able to really continue to give your patients good care and access to you, and to be able to supervise PAs and NPs as well. Some of it's the hassle factors, the reporting, the documentation, the hassle of the EHR that really reduces our ability to take care of as many patients. So you remove some of those things, we can probably take care of more patients. So there's my little roundabout about a number of different things that seem to be sort of out there as I mostly give up practice. But I think prioritization of the issues that we can tackle is the next step. Thanks.
I raised my hand because I have like a different topic, but can I ask you a follow-up on this one? Which
Sure.
is my impression, I mean, you're in Chittenden County. Chittenden County used to have more independent specialty practices. Now Chittenden County has few independent specialty practices, although some. Is the referring different now because it's all going into like UVM? I think I would assume you'd mostly refer to UVM for specialty care. I mean, maybe you go down to Dartmouth too for patient, but the drive times and the challenge of getting through kind of the outside referral system into UVM, is that like and I guess a lot of you probably have similar situations, whether or not, I mean, really the specialty care is in Chittenden County and at Dartmouth.
Yeah, the more we lost independent practice in Chittenden County, the harder practice became. Because, and it's going to happen again as the only independent hematology oncology group sort of goes away now in Chittenden County. The cardiologist went away, the orthopedist went away. And so when you have independent specialty practices, you can pick up the phone, call them, and they'll get people right in. They'll say, send them over. I'll see them tomorrow. That does not happen at UVM. It's always send them to the ER or call the person on call who you don't know, who says they'll get them in and then they don't. And so it's really been much more difficult in Chittenden County as a primary care practitioner because the wait times to get into UVM, even when you call them and talk to them personally on the phone, they say, I can't see them. You talk to the actual specialist and they say, sorry, I can't see them. We won't see them. You can try Dartmouth. And then you have to call Dartmouth. Then you have to call other hospitals, other smaller hospitals. And so that's a huge part of it. If we had more independent specialty practices, care coordination would be a lot better. I'm sorry to say. Does that answer that question?
Yeah,
it does. No, I think it's a challenge for a lot of people to. I work within the UVM system, so when I want to make a referral, I put an order in Epic for the referral and put it as urgent, and I send the specialist maybe a chat message that, hey, I'm really worried about this one. Can you make sure to get them in fast? And it's actually remarkably, it works more often than it doesn't, but I think when you're coming in from the outside, it's a different referral process. Maybe the patient isn't registered in Epic. They don't have a way to assign a chart to them. If it's a new patient. I don't know the challenges and the details of it. I'd be sort of speaking out of turn to really say too much, but I think my impression from talking with colleagues at other smaller hospitals trying to refer patients in, non-UVM associated hospitals, it's a challenge. And then I would assume for primary care, referrals out of non-UVM primary care that aren't going through the typical Epic ambulatory consult order system, it doesn't get in the queue for the scheduler, and it's basically how you build the scheduler's queue. So
yeah, and I guess that gets at sort of these specialty standards for NCQA standards. Even if you don't adapt them, it'd be good to apply them, because somebody's got to force UVM to change the way they do things. Because they have no competition, they've never had to change the way they do things in terms of providing good access, figuring it out, getting people in and getting the information back to them that they need in the community. They've had a really, really deaf ear to that for 3 decades.
Okay. Eileen, please.
Quick follow-up to Paul's comments. One is just to sort out on the CTs and getting CT scheduled. That was one of the examples you gave, whether that's scheduling or insurance or prior auth. And I think that's been answered in a survey that was done in the last maybe 6 months or a year or something. But I just want to make that point and clarify that with you, what the biggest issue is for CTs. And then the other piece about reporting is how many insurances are requiring what, and staff needing to fill out somewhere. Someone has to dig out what insurances want what, and how many places that all needs to go for reporting data.
Yeah, no, it's just timing. They just don't have a schedule. CT, last I knew, was booked out, 4 to 6 weeks to get a CT scan. And so, many of us in Chittenden County, at least, the only way to get a CT on somebody is send them to the ER, because there's no wait and there's no prior auth. Prior auth doesn't hold this up. It's the scheduling. It's the availability of the service.
Michelle is next, and then Dr. Florence, because I'm going to get your name wrong in the beginning. So you're on deck.
Amelia can follow me.
Amelia. Why can't I get it? Because I look at the spelling and I can't get it right. I knew it.
Really, that J. It just really throws people off.
It's a beautiful name.
No, it's a great security feature. If somebody calls me Elijah, I'm like, she's not there. So it's great.
I just want to tag on to this whole specialty care thing. And I want to be very clear that I belong to this group as the president of the Vermont Nurse Practitioners Organization. I happen to work at Gifford Medical Center. What I want to say about this is that across the state, I agree that there are locations in this state where people are waiting 4, 6, 8, 10 weeks for an MRI or a CT or a mammogram or a specialty appointment. I think as a state, we can do better for our patients if we start to think outside our little bubble sometimes. And what I would like to, I shared it to you, Susan. I sent it to you in an email just now, and I'm happy to share it publicly, but I kind of wanted it to go through you first. At my organization at Gifford, there is same day urgent primary care CT available every day. There's a single slot reserved for it. It doesn't have to be a Gifford patient per se. We also have the same for MRI. We have MRI 25 days a month at Gifford and Randolph. And so those services, instead of going through an ED, can still be done at as an outpatient primary care referral. We also, as does Rutland, also has a large scope of specialty care available without a super long waiting list. Next appointment available for our podiatry team is 0, meaning they can get an appointment same day. Next appointment available in our rheumatology department is 0, meaning same day. Urology is 0 for an acute visit or 2 days for a new patient. I could go down through the list, but I think that we have to start, instead of trying to say you have to go to Dartmouth or you have to go to UVM, look at what other organizations have specialty departments. Rutland, I sent a patient to endocrinology in Rutland today from Gifford and got an appointment for tomorrow. So I think that we have to sometimes remember that there's services that aren't just UVM and Dartmouth, is what I guess I'm trying to say.
Thanks, Michelle. Amelia.
I echo a little bit of what Michelle is saying about some of that as well, and what everyone's been saying. I will say too, so I work pretty closely with our referral people, and the other component kind of ties into what Lee's been mentioning. It's the money. It's not even just paying us. I think all of us would say a well-trained RN in your office is like gold. They just do not stay in this. We don't have the support staff to send the referrals anywhere. And what we were told by Dartmouth, they were so far behind. They had 8,000-ish kind of referrals they were floating through because they didn't have the staff to even acknowledge they had our referrals. And so, like what Paul was saying, so now I have to pick up the phone and try to harass somebody to please see my patient. That means I can't see other patients either. Or I'm trying to work with support staff that is an MA that still has pretty new training and has no idea what they're asking for, what they're doing, so it's kind of this catch-22 all across the board. And I think sometimes when payments get brought up, people seem to think it also goes to us. It's across the board. You need the people actually answering the phones and doing all of this work. And so I greatly appreciate also what Faye put together. I agree. I'd love to know kind of what we can do forward, because I do think this group has a lot of people who are still very interested in where primary care is going. And I do think we have a good spread of, DPC, which is still kind of new private practice, FQHCs, plus or minus attached to a hospital, NPs, MDs, things like that. And making sure that there are groups, the AHS, the HEADS model, all of them that are aware we're here for this knowledge and want to offer it. And how as a group can we submit that, like statements, whatever, they're posted onto the PCAG, whatever. But I've enjoyed working with everyone to kind of get to know all the different areas that we can offer and really want primary care to succeed in Vermont. I am also part of the group that's trying to, hopefully for the Maple Mountain Consortium, which is the residency that we really, really want to start, that's focusing on underserved. SQHCs are going to be their main sites of training. Small rural hospitals are going to be their sites of training. We want that. We want them to stay here. And how do we get that out and how do we make that happen? So honestly, just let us know what we can do. That's what I think all need to know is how can this group be helpful?
Can
Go
I
ahead,
throw out
Dave.
an area that's come
please.
up in my life a little bit lately, which I'd love some feedback on? So, okay, I've been pretty knee deep in the AHEAD model. The federal administration changed. We haven't had any formal description of the policy change that's come to us yet, at least in a way that I feel confident with. Nothing's written. But clearly the new CMMI director comes from a background of significant interest in ACOs, Medicare Shared Savings ACOs. And now that OneCare is not attributing lives, and this will change when UVM is apparently signing up with a new ACO, I can't remember which one it is, that Vermont actually has basically the lowest ACO penetration in the country, because now we don't, once you remove OneCare, we have pretty low ACO penetration. So I think there's going to be interest in more Medicare Shared Savings ACOs in Vermont and serving our Medicare patients. And there's some advantages of that, because then many of them will get you out of MIPS reporting that has never been guaranteed to be waived within a head. So there's some potential benefit of reporting, but I don't know. I just was curious what people think about all this and how to think about this. We're going to regulate ACOs, and there's
Back to the future.
a lot of options. Yep.
Yeah. Paul has history with ACOs, right, Paul?
Yeah, we had
Way
the
back
first
when.
we had the first Medicare ACO, Green Mountain ACO of the Green Mountains. And it's amazing that we're still talking about Medicare ACOs in this state. We proved it with our ACO and United Healthcare subsidiary, I forget what they were called, that we joined with to do it. We were doing great, but they fired us. They had to get out because you can't make money with Medicare ACO in Vermont. Our utilization and costs is already one of the lowest in the nation. These folks who are coming to fill this gap, they just are ignorant. And I mean that in the nicest way. They think there's money to be made here. There is not money to be made here in Medicare ACO. You can't make it work. We worked with another one a couple of years ago, just Evergreen did, and there was another couple practices that did, called Clover. They tried the same thing. They said, no, we're going to dump you. We were doing great in terms of utilization, but it wasn't better than what had been happening. It's just not doable in Vermont. So these new, UV, I'm sure they'll try that, just like they tried, a program with MVP. That didn't work out, the Medicare Advantage plan. They had to drop that. You can't make money. There's no shared savings in Vermont because our utilization is already too good and our costs are already too low. And it also begs the question why we keep pursuing things like AHEAD, which is based on, a Medicare ACO again. That's not where our problem is in Vermont. It's with the cost of commercial patients' care, not their quality, not their utilization. It's the cost of their care. And so, again, that's in my soapbox, but just the warning with these other ACOs that are being picked up on, they're going to go away in a couple of years because they won't work. We proved it over a decade ago. So sorry for that bummer.
No, well, so a lot of it too comes into like, what's the benchmark price? What's the PBPY that they're benchmarking you to, and so I think that's a bit of the challenge. With Vermont.
They originally benchmarked, the original one we were part of benchmarked you to your own previous, and you had to approve by what you were doing. They eased it up by doing regional benchmarks so that you could get a little bit of benefit from, sort of beating the region, but you were still based on what you had previously done. So they were basically rewarding those ACOs that were the worst, that were absolutely the worst. And if they improved it, they got a lot of money. And the only way that ACOs found that they worked to make money were two things. One, by more coding. Code your patients to be sicker so that you get paid more, or that your benchmarks were now higher.
It bumps up your HCC score.
So up the coding. And that was the major thing that both the ones we worked with tried to do. Number two, steerage. Steer to lower cost sites of service, lower cost hospitals, lower cost imaging centers, lower cost, outpatient versus inpatient. And we don't have that in Vermont. We don't have those alternatives. They don't exist. And these ACOs that came to us as well, let's see, who can we have people sent to that are lower cost? We're like, there aren't any. We don't have those options. So that's the other reason why it's really not something that's going to succeed when it's based on, sort of ACO Medicare based. If there was ACOs that were truly commercial based on cost, now that's something different. And it included everybody. But good luck to us with that.
Anything else, Dave, before I move over to Lee on the ACO topic?
No, I mean, I think it's my understanding it's coming.
Mm-hmm. Which
so.
wasn't expected in, this is new with the new administration, to be clear.
Yep.
So a bit of whiplash. Go ahead, Lee.
Well, that's kind of distressing, but we'll leave that where it is. It was one of the things that I really want to get, maybe PCAG or maybe just everybody, is to start thinking outside the box. We keep hearing the same old solutions, and they don't work. And then we say, oh, but it'll work this time. We know it. And it won't work. And it doesn't work. So we need to start thinking outside the boxes. And, one of the ones that, partly because it's the way I do it now, but, if Medicare paid primary care capitation, so that there's no billing, no hassle, oh, Lord. That would be something that they would have less paperwork, we would have less paperwork. And you could set it at a rate that, even if you paid me what I used to charge, but now I don't have to do all the billing and they don't have to do all the billing and payment and all the bookkeeping that goes along with, the deductibles and the co-payments and blah, blah, blah. It's just, it would save a ton of money, but it wouldn't, show up on the books per se. And that's probably what we need somehow, but I don't know how to make it appear on the books, but, we need to think outside the box and stop thinking in the old boxes, because we're not going to change the outcomes when we think in the old boxes.
I totally agree with you. I do think from the, I got really excited about global budgets because I was like, wow, you're just going to pay us to do the work and then we don't have to do all this dumb billing stuff. But the problem is that there's a shadow billing that's running behind the whole thing because claims data runs all of public health data. So you got to still submit claims. And then, from a Medicare standpoint, they've got the Medicare Trust Fund regulations that they have to deal with to show that the money is actually being used for to give Medicare patients care. So I don't think it's in the foreseeable future that we're going to get rid of billing and coding. I think that the system is wed to it. But I do think thinking out the box and ways to fund primary care more, whether it's capitated payments, whether there's a lot of interest that, say in some practices, Rhode Island, that negotiate more capitated payments from insurers. Is it, we talk about fee for service rate settings back in the world again. And I think the way I read the statute, we could rate set up places and work on trying to rate set down places, and primary care is a place that I think we could try to figure out how to increase reimbursements for, and that's something the Green Mountain Care Board could be involved in. I think, we're having these, I'm not in these meetings, but there's people having these meetings of like, oh my gosh, like our healthcare system is an incredible amount of strain right now with Blue Cross Blue Shield solvency, with hospital insolvency issues, insolvency of Blue Cross, with service loss in areas in primary care, and I guess I'm guessing that we probably could use more primary care at the table. And, these are sort of early conversations and many conversations around the place, but I think even some representatives from this group, I'm just throwing out an idea. What if we had a representative from this group? I think Faye mentioned a chair or something, maybe a chair of the PCAG could get involved more directly in some of these kind of meetings. I'm just throwing out ideas, just spitballing ways that we could leverage this experience.
And thanks, Dave. The other thing I just want to say before we wrap up, and I made a list of follow-up items that I want to review with all of you, make sure I get everything. We work with Milbank. Is it Milbank, Peterson Milbank, Dave? It's like a philanthropy organization that works across states on health policy issues, Milbank. folks have heard of that.
I forget, there's a funding mechanism between Peterson and Millbank,
yeah,
so I just
I'm
call
gonna
it
get it all
Peterson
wrong.
Millbank.
Yeah.
So,
but Rachel Block is somebody who used to be in Vermont years ago, worked in Vermont. She now is, I think, their executive director. And I talked to her a little bit about, like, she has a lot of information across states on what other states are doing around primary care. They have some ideas around primary care. There's that still that primary care spend work that I know this group has talked about. So I just jotted that down as something that might be, we could bring her in and she could share some things that are going on in other states if that's something of interest to you. Eileen.
I always circle back to, in the interest of next steps and scheduling.
Yes.
I'm wondering about scheduling another meeting sooner than whenever the next one is. And then maybe a handful of people getting together ahead of time to just gather this information, ask people what their priorities are, and then put together a suggested priority list for then the group to review to start picking away at this.
I love that idea.
I don't want to, I'd hate to lose the end of this meeting and then we're doing this again. We did do this before. It has worked really well as a group when we did this and did some offline work. So I don't want to lose that passion, as was said earlier, that we did have before. So.
And if you volunteers, I know Eileen has done this offline before and has been wonderful. But if she could get some, maybe a couple of other folks to work offline, or you all can work offline, we do have to, we are an official committee of the Green Mountain Cure Board, so we are governed by public records. So I think I can share our charter and that, and I could talk with you, Eileen. I know you worked with Faye offline before, but polling the group on different ideas, as long as we come back and report it out, we just don't want, it's an actual number of people who can't meet as a quorum outside of this meeting. So a 2 or 3 is fine. And then from the Green Mountain Care Board side, we will come back with things that we would like your input on. Something that's right before us is the thing that Dave brought up about this agreement with UVM, this proposal, excuse me, from UVMHN, and that just came before the board today. And there will be questions about primary care. So we will be reaching out on that. I'd encourage folks to take a look at that. I have a list, but I want to pause to see if Eileen, did you want to share something else? You came off mute.
Just to remind people, and we did this before, there's a few of us that did this, we did put it right back out to the whole group. So it's not like a subgroup made decisions or choices or planning going forward. It's just easier for a small group to then get the feedback and update it and change it from there. So
that's great. Faye, Eileen, would you mind taking it like the first step on that with the group? Or oops, you're on mute.
If I see some hand raises or head nods that people support that, we can do it if it did be. There's Faye.
Faye has 2.
But again, like I had said earlier, getting feedback or the right people at the table to determine what can actually happen and making some change happen, I think we can.
Sounds great. I have on my to-do list from the Green Mountain Care Board side, clean up the membership so we can update the list of, make sure the list reflects active members. I think something we can talk about is membership that goes along with the charter. And so I can look at the charter and suggest changes. We can do that at our next meeting. And then we need to schedule a meeting so we can reach back out. I'm assuming Wednesday night is still good for you all, but we can even send out a doodle poll and see what works. But we can get that on. What's the timing you're thinking of, gang? Next month, like a couple of weeks?
I think we could probably do it in a month.
Yeah.
Because
April
people
is, yeah.
are pretty good about responding in the past. So
Okay, we'll follow up.
Susan, can I throw one more thing on the
Yeah, please.
GMCB side to-do list if you're
Yeah.
keeping a list, is to
I
reach
am.
out to AHS
Yeah.
/ Diva. If I didn't, might be on there. Sorry if I missed it.
Yeah. And, you know, they have a primary care advisory group as well, or I forget what the acronym is, that they have started related to AHEAD, I think, Dave, and healthcare reform. But it had.
I'm on it with Pat Jones.
Okay, so you know that group. It's larger and it's less clinically focused. Like there's less clinicians. As I recall, it's important to get. It actually is a nice complement, I think, to this group. It's just a different lens. But I will do that. Thanks.
When you say less clinicians, like more practice manager type?
I think it's pretty much like myself. I want to say there was a PA that works out of Rutland and maybe one other routine provider that shows up to kind of do that. The last one where she was looking at what metrics to be used, I couldn't make the very last one, but the one before that, she was getting data from bi-state and VTAFP about what their thoughts were, but actually on the ones that meet, there's maybe 3 or 4 of us out of the whole group, and it's not consistent because most of us are also seeing patients because it's during the day.
Is Amelia, is this the one with like the association leads as well? Are they on that too?
I believe so, and I think there's some of the oh shoot, it just blanked. I want to say Blue Cross. I could be wrong though.
I think so. Is this the one that
more
just
some of the
met,
insurance aspect too? I think. Yeah.
So it's a lot broader than this one. But I will do that too, Dave. Thank you. Reach out to AHS folks. All right. In a few minutes, I want to take public comment if we have any members of the public here. Lee, go ahead.
I just wanted to relay something. I haven't been able to confirm this, although it did have a DOLs for Department of Labor at the bottom of the slide, but this is a slide that I was shown at the physician wellness program that the AAFP is running. And it was just the scariest slide I think I have seen in my whole career, where they showed from 1970 to 2010, the number of physicians in this country went up by 75%, which they said not really a big deal because the population went up by 50% and it got older. And there's more stuff that we can do. They then, on the same graph, had the number of administrators in healthcare, and it went up 3,300%.
Wow.
While the physicians were going up 75%. And so anything that includes a whole lot of administrators, I look, sorry to you administrators, but I look a little bit askance at, because I just think that they've come to dominate what we do. And that takes some of the joy out of what we do. So.
Thanks for that, Lee. We will, the membership here will stay focused on clinical focus. So, and I really value that. Great. Anything else? This was a great discussion, and Faye, thank you for getting the ball rolling on this. We really appreciate it. We do have it recorded too, Eileen. If you want the recording, we can send it to you if that would help.
I think between notes that you took that you're going to be
Mhm.
sending out, what we can do is just put that together.
Great.
I can always use the recording as well, but I think once this gets put together and sent back out, people's brains are going to be working between now and then and coming up with other things that
Yeah.
we will add anyway.
Great. I'll put it out there for any public comment. Oh, Eileen, I just saw your note. Can PCAG suggest some guidelines for yes, membership? Nope, the charter is our charter. It's not from the legislature. We wrote it and shared it with you, and we can put that out again, and we can wordsmith that.
It seems like there's a lot more tasks out there than just administrative burden
Oh yeah.
that we need to.
And one thing, Susan, maybe when we're cleaning up the list, if there are people where it's sort of uncertain how engaged they are, maybe we put out an email that there's been discussion about being a more proactive group and doing a little more work between times, and just sort of asking people who seem uncertain as to their membership whether they're committed to that or not.
Yeah. Sounds good. Will do. And Faye, you have a few folks who are interested in joining, right?
I do, and I wonder, we don't have to decide that tonight for sure, but maybe think about whether we throw the door open wide to people who are newly interested, or whether we look at, I think maybe we need to look at sort of our the groups that we want to make sure are represented, and make sure we're not getting too lopsided. But I would welcome some fresh voices. I just want to make sure we're not getting too lopsided with any one group. I happen to know a lot of family doctors in the Northeast Kingdom who work for FQHCs, and if that gets to be too much, then so be it. But it's something we can probably discuss at the next meeting after we've kind of looked at the groups.
That sounds great. That could be part of the charter, or it could be a application process. The application process is pretty straightforward. Send your CV and your request to be on the group. But I think taking it the next step of geography, clinician type, etc. So, we love the family doctors in the Northeast Kingdom who work for the FQHCs. We don't want the entire practice to be that, or the entire PCAG. All right. Well, anything else before we adjourn? Thank you all. We'll see you in a couple of weeks. Sounds good. Thank you.
Thanks,
Bye-bye.
Susan.
Thank you.
Thank you.